about breaking bad news. This is one aspect of our work that is quite challenging, communicating with patients and families. And so we are going to spend the afternoon just looking at how we can be able to break bad news in a more effective way. So our first presenter is Dr. Marianne Phillips, who is an associate professor. She works as a pediatric specialist in oncology and palliative care in Australia. She has vast experience in humanitarian settings, and she's going to take us through the lecture on breaking bad news. Welcome, Dr. Marianne.
I think, Dr. Esther, you couldn't hear me when I was sharing, but she's actually been caught up with a client in.
Yes.
That's okay. It's okay. So I'll share her, but if you maybe can watch the waiting room, or let me know if she comes on, and then I can pass it
No
over
problem. All right. Please carry on.
All right. So we are going to be talking about breaking bad news. Let me just change it to the slideshow. All right, can everyone see that here? Okay, so when we begin to think about how to break bad news to patients and families, we want to take a perspective of how to outline what are good components of communication. So we often will talk about applying active listening skills in interacting with our patients, because this tends to improve how we communicate with families. And then there's a specific model that we want to follow, and it's called SPIKE. It is SPIKES, and it's the acronym that will help us remember how to give the bad news to patients and to their family members. So hopefully by the end of the session today, you'll be able to follow through on these 3 objectives. So communication, the NHS Cancer Plan back in 2000, so it's quite an old definition, but NHS is the health service in England, said that good communication between healthcare professionals and patients is really essential when we deliver and we try to deliver high quality care. So as you think about your setting where you're working, I think ultimately that is our goal. We want to make sure that all the care that we provide, whether it's primary care, whether it's public health initiatives, we want to make sure that we deliver these types of care with the highest quality. So making sure that we communicate well is one way for us to focus on that. So it can really influence a patient's emotional health, their symptom resolution. So sometimes if we know that we can communicate well with our patients and families, they have decreased reported pain and drug use, as well as their function and physiological measures. So for example, blood pressure. The research shows back in 1996 that if we are able to communicate well, it can begin to influence the patient fairly holistically. So as we think about communicating with families, we know that good communication reduces uncertainty and anxiety. So I want you to think of this patient here. They are living in a rural part of Kenya. And here you can see the patient who's in a wheelchair, and then his caregiver is there along with the nurse that's in the blue uniform. So here you can see that they are discussing medications. She's writing out some notes on the client's file. And the family member is quite involved in the care as well. So we know that good communication also builds trust between the family and the healthcare workers. It ensures that collaboration is part of the process of care. And it also helps to explore any concerns. Sometimes our patients are concerned about something and they let us know. And sometimes they are concerned about something, but they don't tell us, that it's unexpressed. But when we have good communication skills, we are able to identify these concerns. And overall, we know that good communication improves the satisfaction of the care that we give. So on the other side of the coin, when we think about good communication versus consequences of poor communication, we know that in palliative care, if we cannot focus on and improve how we communicate with our patients, we know that they have decreased confidence and trust in the care that we are giving. There's significant distress or confusion related to diagnosis or even their prognosis. We realize that families tend to not reveal important information. So they might be holding back details during a family meeting. And patients and families choose or insist on ineffective care. So sometimes you're in a family meeting and you've given all the options to the patient and the family. And because you haven't communicated in a very clear way, they choose something that's not in line with the medical team, or they choose or they insist on care that isn't really in line with our goals as a healthcare team because of the way we have communicated it. So these are pretty clear consequences of poor communication. And I think as healthcare providers, we know that this isn't something that we would want to happen in the situations when we're supporting patients and families. All right, so I want you to go to the chat. I see there's a bunch of people introducing themselves, but I want you to think and put one of these that has happened to you. So when we have poor communication, we know we can't be perfect all the time, but can you think in the last week or so when one of these kinds of situations has happened with your patient or family, that they become angry, depressed, confused, worse, possibly symptomatically not valued, distressed, or they lack trust with you? So just share. It's hard to be completely honest, but this is a safe environment. We say that week in and week out that we want you guys to feel safe and comfortable sharing. So if you feel like you can put in the chat on a time in the last few weeks when you've had some poor communication with your patient. It could be a home visit. It could have been at the bedside. It could have been in a clinic. All right, so I can see a lot of people putting in that not valued. The patient feels not valued when we don't communicate well. Sometimes we lack the trust. So we're losing trust with our patients when we have difficult times communicating. Distress, yeah, it can definitely, if we have difficulty communicating about someone's diagnosis or prognosis, actually patients can feel quite distressed. Anyone else? Anyone? Okay, worse symptomatically, depressed. These are all real things that we face. Whether you're a nurse, whether you're a clinical officer or a consultant, maybe you're a chaplain or a social worker. We communicate with our patients on a daily basis. And when we don't feel confident, especially when we're talking about fairly difficult situations, when someone's prognosis is poor or they're declining, it's really hard. And we feel it because of the way a patient feels it. They don't feel valued. They feel distressed, confused. All right, let's go on to the next one. So what's the most important for families, according to research done in 2000, is that healthcare professionals show honesty and empathy. So we need to make sure that we give adequate information that's clear and understandable. So the way that you communicate with someone who is highly educated compared to someone who maybe hasn't passed their primary education is different. We need to give the information that's relative to who we're talking to. It needs to be understandable to someone that may be illiterate but it still is really important that we communicate with families in this way and patients. We need to respond to their concerns, as well as we need to be very attuned or give attention to their emotions. We know in palliative care, oftentimes we're talking about very difficult situations, and many times when we're breaking bad news, it's because a patient isn't able to be cured of their disease. So they might have been diagnosed with a chronic illness, and we need to make sure we're aware of what are the emotions that our patients and families are showing us. Discussions of what can be done with realistic goals. So this is really important. We know in many of the settings that you guys are working in humanitarian settings or refugee camps or very rural settings, sometimes we are not able to access high quality care because of where we are or because of barriers that are out of our control. It's really important, and we'll talk about some of the skills today about how we can do this in a realistic way. So we talked a lot about hope a few weeks ago when we talked about communication, and sometimes we need to help our patients and families re-identify what they are hopeful for, and that especially is important when we talk about goals as a family. And it also in 2001, research was done that said families also really wanted to be included in decision making. So decision making is really important as well when we talk about what is so important to the families that we take care of. Okay, so we've talked a little bit about good communication and the outcomes of good communication and the outcomes of poor communication. We've talked a little bit about the reality of what you see in practice when you feel like you haven't communicated well, or maybe you have observed a colleague who hasn't communicated very well. But for you to be a good communicator, so if you're taking notes today, you can write these down. Of course, we'll share the slides like we always do, but these are a few points that I want you to remember. How can you improve your practice when you're providing palliative care, or you're trying to include a palliative care approach in your work? So you need to be knowledgeable. You need to have all the facts. So if the patient has been admitted and you're waiting for some test results, you need to let them know that. You don't want them to be nervous as they're waiting for their test results. You try to the best of your ability to give them accurate timelines. You know, we're hoping in the next day that we'll have the results of this test, and then we'll come and sit with you and talk to you about what the test shows. It's really important that you review the chart before you talk to a patient, especially if you are going to be sharing a patient's prognosis, that you are knowledgeable about the situation, what happened before they came to the hospital, and then what is currently ongoing. It's really important that the purpose of the discussion is clear. So in some situations, we have family meetings where we discuss a patient being discharged. So possibly the patient's symptoms have been managed, although they have a chronic illness, they are hoping to go home. The purpose of a discussion when you're trying to help a family be discharged will be quite different than the discussion of a person who we identify that they had quite severe symptoms, and we were able to, through the diagnostic test, show that they had advanced cancer. That discussion is quite different than if someone is preparing to go home. And we need to make sure that the purpose of those discussions is very clear. We need to be sincere and empathetic, and we'll give you some examples of how to do that well in your work. And sometimes at the beginning, when you're getting used to having these kinds of discussions and conversations with patients and families, sometimes it is okay to say very similar empathetic phrases to all of your patients that you're speaking to in these ways. It's okay to say something very similar, because eventually, if you say the same thing, obviously based on the situation, you can be feeling more confident, and then you can, of course, change the way you say it, and that might become more clear when I share the example. It's really important that when we speak to our patients, we speak plainly. and clearly. We don't want to use very complex medical terms. Again, if the patient is a clinician or they're a nurse, of course, that's different. And they may want to know that information in medical terms, but not all of our patients are healthcare professionals. And it's really important as we communicate with patients that we identify the nonverbal clues or cues that they're showing. So are they avoiding eye contact? Are they sitting with their hands crossed like this? Are they crying? Are they kind of breathing quickly? These are some nonverbal signs that someone might not be feeling like they either want to continue the conversation or maybe they just need a little bit of space or you just need to sit in silence for some time. All right, as we think about one of the skills that we wanted to identify, it's called active listening. So you might have learned this in medical school or nursing school, but it is really good to be reminded because very quickly we get in the habit of talking a lot during these discussions. So what we want to do, we obviously know that when we are sharing new information about a patient's diagnosis or prognosis, that we have information that they don't know. But a huge aspect of the conversation is also us listening to them. And these kinds of conversations may not happen just one time. This might be a few different events that you have interacted with the patient in the past. So it's really important when we want to focus on listening and we want to understand the patient's situation or the family situation, that we let the other person speak. And last time when Gladys was talking a few weeks back on communication, she had the 80-20 rule, wasn't it? And where she said that we need to listen 80% of the time and speak 20% of the time. I think this is something that we might remember on paper, but it is hard to remember that when you're actually in a clinical setting. You only want to interrupt when there's a need to do so. So as you're hearing the story or as you share some difficult news and a patient begins to respond, only interrupt their story when it is absolutely necessary. We want to encourage people to talk. We want to encourage the family to talk. You want to also listen for hidden questions. So there might be times when someone is asking a question, but maybe there's something underneath that. We know in many of our East African cultures that we can sometimes be implicit with the way that we communicate or the way that we talk. We're not always so clear on our questions. So what are some of the underlying questions that someone might be asking that we can really try to listen hard to? Of course, we remember from our last session, we want to allow for short periods of silence. And this is all included as we build our skills for that active listening. All right, so what is bad news? I want you to go back to the chat if you're able to. And of course, I have it on here. Bad news is defined as any information that's likely to alter drastically their view of their future, or it results in a cognitive, behavioral, or emotional deficit or change in the person receiving the news. So what does bad news mean to you? Those are kind of very high-level definitions of what bad news is, but what is bad news to you? I want you to write an example of what bad news is, either in your personal life, if you've ever been shared with from a clinician what bad news is, or if you've ever shared bad news with someone. So tell me what bad news is to you. Yes, unexpected information. Sometimes people come to the clinic and they weren't expecting a serious diagnosis. So definitely that would definitely be defined as bad news.
It can be also a worry information. People are maybe worry about it, that it can be dangerous.
Yes, for sure, because the information is not clear. Maybe that's also bad news. There's some misconceptions about a diagnosis. that could also be perceived as bad news to the patient, where we thought it wasn't necessarily bad news. You're right. Ali, I think you have to leave. That's okay. Just join us if you can later on. We'll probably be on until 5:30. Okay, Anita says unpleasant information. So there might be something coming up in the future that may make someone, feel really bad because the information isn't nice. Kim, I see here you put a loss of a dream. You're right. What if we had to share some difficult news with the patient after they were in a car accident, and the dream of that person, or some sort of trauma that the person had, physical trauma to their body. They were an athlete in their community, and they were always, playing football or one of the fastest runners. And then they were in an accident, and the team has called on to the palliative care point person to share that this person is now paralyzed. That loss of dreams is really difficult to share bad news like that. I see people are sharing in. Bad news to me is information that causes distress. Yeah. If you're getting information about maybe someone is diagnosed with cancer, that would cause a lot of distress. Unpleasant information, something that's unexpected or might disrupt any calmness that I have in my life. Yeah, for sure. Information that affects an individual negatively, for sure. A worrying information, worrying message, something that changes your consciousness, threatening. Yeah, any news that can affect someone's emotional state, for sure. So we often think about, in palliative care, we often think about bad news related to someone's prognosis. So it could be when someone was initially diagnosed with a life-limiting illness, such as cancer, or kidney disease, or liver failure, possibly congestive heart failure. We know also it can be for children. We talked a lot about children's palliative care with Professor Julia, but maybe a family is being told that their child has a congenital defect and they won't live very long. All of these kinds of things would be what we would consider bad news or difficult news. And ultimately, within palliative care, we want to become quite skilled and known for doing this in a very open and honest way. And this is what we're going to talk about today. There's a few steps that you can take. We do want to, when we do share this kind of news or new information about someone's health, that you speak to a family together. If the parents are there, you would want, or if just one caregiver is there, you would want to invite both parents if it is a child. And then if it's the adult, they have a spouse, you would want them to be involved as well. You do need to give plenty of time. I know Dr. Nafula is on the call with us today, but I'm sure she's had her fair share of family meetings that go quite long. Generally, when you're sharing news about a prognosis, I would recommend scheduling at least half an hour to spend time with the patient and with the family, if not more. I know oftentimes you're very busy, but it is really important that we give enough time to do this. Again, we need to involve the family in decision making, and we do need to acknowledge that the family is actually the expert in a child's care or in their loved one's care. So not obviously just the children, but a spouse or a brother or an aunt could be an expert when it comes to care for the person that is sick. And we need to make sure we acknowledge that. We don't want to isolate or make a family feel like they're not important in these decisions. Okay, so why is this so hard? Okay, back to the chat. You guys have been very active on the chat. I don't want to show you the answers today, but why is it hard for us to do this? As a physician or a nurse, why do we feel very nervous when it comes to sharing health information with our clients that may not be good news. How does it make us feel as healthcare providers? All right, yeah, we don't know what to expect. We don't know how someone is going to respond to the news. We may not know the patient very well. We may not know the family. Maybe we don't know their history. Maybe someone in their family has recently died of cancer, and now we're going to tell them that this patient has also been diagnosed with cancer. They might be very angry at us. We become very attached to our patients, you're right. So it can be difficult, it can be challenging. Maybe we don't want to tell them that the prognosis is poor. Yeah, Melchizedek, we often fear emotional reactions. I think in many cultures, my culture is from Canada, originally from European descendants. And I know in many cultures, when someone starts crying in a doctor's office or at a nurse interaction, it can be very awkward. It's very natural when someone is being shared difficult news, but it can make us nervous. We don't want to see our patients cry and our loved families cry. So maybe we don't want to then share the news. How they're going to react, yeah, we don't always know. Sometimes it will impact their mental health. So say maybe one of your patients has been very anxious about the future or showing signs of depression. And we know that we have some information that we need to share with them because we need them to make some decisions about, you know, their plans or, you know, what treatment they're going to have. But we think that if we share this news, they're going to be more depressed or they're going to go into an anxiety attack. Sometimes we don't do it because we don't know how. You're right. Mohammed is sharing that sometimes there's a knowledge gap of how to do this, actually. So you don't do it. Maybe you haven't seen anyone do it very well. All the times you've witnessed one of your colleagues break bad news. The situation is very challenging, it's very stressful, so you just avoid it. Yeah, definitely emotional and physical reaction from a caregiver. Maybe you're sharing with a family member that the child has, I think we did a case of this earlier where a child has a congenital defect where they have a hole in their heart and the child is not going to be able to access surgery because of where they're currently located. And you need to share that the child may not live for very long. A father or mother might get violent towards us when we say these kinds of things. Sometimes we don't have skills to do this. And we want to sympathize or empathize with the family for sure. Bad news might bring cardiac arrest to some patients or family members. So sometimes the shock of news can be very physical. It may cause anxiety or high blood pressure for sure. Those would be all reasons why we would want to avoid it. Okay, so here from our healthcare worker perspective or a physician's perspective, sometimes we're fearful that we're going to cause pain. It might be a failure. We might get blamed. There will be an emotional reaction. You guys have said most of these, and it might be upsetting to the family. We also sometimes avoid this because we don't have training in how to do this. We don't have the time. We don't have half an hour to an hour to sit with a family and a patient to discuss their situation. And we sometimes don't even have support from our colleagues. I know many people that work in humanitarian settings, maybe just one or two that have had some training in palliative care or support from their colleagues to do that. And some real things that we haven't talked about so much and didn't come through on the chat so much are the cultural constraints or language, or even the system, the healthcare system doesn't really allow us and doesn't really empower us to do this. From a patient and a family perspective, often it's difficult because patients have vivid memories of receiving bad news. So they may have had a situation maybe where maybe their parent was very sick and someone told them that the parent was going to die and it wasn't done in a very empathetic way. So they might think back to that moment and they get very bad memories of that. Or they've had negative experiences that can have lasting effects. I know that had shared in the chat about this related to anxiety and depression. It can really affect our patients when we don't do this well. But after we think about that and we identify some of the barriers as to why we wouldn't want to, within the palliative care approach, and it's a global approach, it doesn't just happen in Kenya, it doesn't just happen in the US. This is skills and techniques that are far-reaching. It crosses cultures, it crosses countries, and it's a fairly simple model. We obviously want to make sure it's contextualized. So the way that we do this, these steps for spikes in Kenya might be very different than the way they do it in Egypt, or the way they do it in South Africa, or in Bangladesh. But we want to teach you how to do this, and then even you can print the acronym out and even put it in your office so you can be reminded. So first of all, S stands for setting. Then P is perception, I is invitation, K is knowledge, E is emotion, and S is summarize. So the first thing we want to think of, and I can share this image with you so you guys can print it out or save it on your phone, just to be reminded, is setting. So when we think about the environment that we're in, when we're trying to share some difficult news, we need to think about who is important to be at the session or the discussion. The patient, of course, the family members, maybe the person who's making medical decisions for the patient, maybe a close friend or someone that can support them if they're going to be hearing some difficult news. What needs to be told, so we need to make sure we have the exact facts. If it's a diagnosis, we need to make sure we know the clear diagnosis. When, we need to make sure it's a convenient time. I was suggesting 30 minutes. I don't know, Dr. Esther, if you can put in the chat how often you spend with patients when you're sharing difficult or bad news, but I would say 30 to 40 minutes. You don't want to rush these kinds of conversations. And this kind of interaction should be done in a very quiet or private area. So shouldn't necessarily be done. All right, Dr. Esther says an hour to possibly an hour and a half. So you need to really set aside time in your schedule to do this because you don't want to be rushed. You want to be able to listen. You want a private area. So usually we recommend not to have these discussions at the bedside because most of our patients we see in a ward. If there's a room, even a staff room, if it's quiet, or a conference room or a discussion room where you can go and have this family meeting, that's really important. And then of course, why are we meeting with the family? We need to know these details before we schedule when it's going to happen. Logistically, if you can, it's nice to have tissues or something to offer for loved ones if they are going to cry. Some cultures are very open about their emotions and they cry a lot. And it's important that we sit at eye level. So if you're having a discussion with possibly a teenager, you don't want to be standing over the side of the bed and discussing this. It's quite a power imbalance. Of course, there's already a power imbalance because you're the healthcare professional. But you want to make sure you're sitting at eye level with the patient. And I do recommend sitting. It's not a good idea to stand while you're sharing this kind of information. You do want to minimize any interruptions. So having your phone on silent or just turning your phone off. I know that's not always possible for most healthcare workers, but not taking phone calls is really important. And then also check in with yourself before you do this. Take a few deep breaths. Identify if you're feeling upset about something else. Maybe today is not the day to share this information, or maybe your colleague who's also had some training in breaking bad news can share it. All right, so perception. So we always want to get information from the patient and the family before we give information. So this is the next step. So asking some good examples. Again, if you have your paper and pen, these are really good examples to write out and make sure you have them in your notebook. Because it's okay for you to say this every single time you break bad news or you share a diagnosis or a prognosis. What have your doctors told you about your child's condition? Or what have your doctors told you about your condition? And what is your understanding of why your child or yourself is sick? What this does is this helps us identify if the information that we're planning to tell someone they already know. Sometimes we think patients don't know very much information, or families don't really understand what's happening with the patient, but actually they do know. So this is a really, really important step, and it may actually change the outcome of the discussion. The next one is invitation. So SPI, I for invitation, is ask permission to tell more. So we want to make sure that we ask somebody if we are able to tell them more about what's happening. So for example, can I tell you more about what is happening right now? And ask for preferences. This is really, really important. How do you prefer to discuss medical information with your family? Or how do you prefer I discuss medical information with you? In many cultures, the person that is sick isn't always the person that gets all the medical information. And I know this is a really big deal in many of our situations, especially in Kenya. That's where I have most of my experience in East Africa, but most of the time, the family wants to know the information before the patient knows. And we do obviously want to be very true to cultures here. We don't want to make people feel awkward or that we're going behind somebody's back when it's actually more normal in the culture to share with a family member than the patient. But I believe it is really important that we ask the patient. We don't have to outright tell the patient if in their family dynamic, it's actually more appropriate to speak to the spouse or to one of the siblings. I think it is quite important that we ask the patient, do you prefer us to discuss with you or your family? And oftentimes in healthcare, doctors or physicians are the ones that deliver bad news to families. So they give a prognosis update or they give a diagnosis. And then nurses are the ones who give more elaboration and clarify after the first meeting. So these are often done not just one visit at a time. And then on to the next step, knowledge. So we need to make sure we give information. So one way you can do this is by giving a warning shot. So you say, I have something serious we need to discuss. You give the facts clearly, and then you explain what the results mean in plain language, and you pause. So the cancer that your child has spread to your child's liver, and it is getting worse despite the treatment. So that's very clear. There's not an area for there to be confusion. We've shared here that the cancer is getting worse, and even though the treatments are occurring, it's continuing to get worse. At this point, once we've shared the information with the patient and their family, we need to allow time for silence. We need to show empathy by allowing silence and allowing time for emotions to come. We need to listen and observe for any emotions the patient, the family may have. And we need to encourage the family to share how they're feeling. It is important that we stop talking if someone has very strong emotions. If someone's crying, you don't necessarily want to speak over someone who's crying. You want to sit with them. Here you can see in this image, the physician is at the bedside, but the patient looks very distressed. So maybe during these moments, it's not the most helpful time to continue to talk about the diagnosis. We just need to leave time for silence for them to understand what's going on. Some useful phrases to show that we have concern and we are connected with their emotions are saying, I wish the situation was different. I think many of us can agree that this is a phrase we could use with many of our patients that have palliative care needs. And I know Gladys went over this before, but one other thing to remember is the nurse model, so NURSE. And I can share this on the chat after, but sometimes it's helpful for us to name the emotion. I see that you're feeling very angry. Sometimes our patients can't always share what they're feeling, but if we can see the emotion, we can also help them express it, understand, I expect most people would feel this way in your situation. You have shown remarkable courage. We will support you through this. And sometimes it's helpful for us to explore how people are feeling. Tell me more about how you are feeling. These are those examples of things that you could say to many of your patients, and it is okay. These are very good responses to show that you're giving empathy to them. Another example is the 3 W's. I wish, I worry, and I wonder. Sometimes we have our patient or family members say to us, I hope I will get better, or I really hope they would be cured of their cancer. How do you respond to that? What you could say is, I hope that you will get better too, but I'm worried that this might not happen. And based on what we've seen with your condition so far, I'm worried that there is a chance your health may deteriorate quickly. And I wonder if we should talk about that to make sure we plan for how best to care for you and understand what you want in this scenario. Or you could say, I wonder if you had more information, you might make different decisions for the time you have left. Again, these kinds of phrases are not easy to say, but as we reflect on them and maybe we put them in a notebook, we can continue to have a bit more confidence as we use them. I know Dr. Esther spends a lot of time, Dr. Esther Nafula spends a lot of time in family discussions with people, and it is easier as you do it more often. Sometimes our patients might say, I'm hoping for a miracle. Here you can see this lady is extremely distressed. She's got her hand covered. She's not looking at anyone. She even has her bag in front of her. Clearly, she's just heard some really difficult news. What we could say is, I hope that you will get better, but I'm worried that this might not be possible. And there is a chance you could get sicker quickly. We're being very honest, but we're also wishing with them. We're also hoping with them that they will get better. We're empathizing with where they're at. And the last step of this spikes model is to summarize and to come up with a strategy. So we need to make sure that the patients and the families understand. So do you have any questions for me? Is a simple way to ask that. The other thing is acknowledging. Today we've talked about a lot. Can you tell me what you understand? It's important that when the patient leaves, it's clear. They might be in shock and they may need time to fully process, but it's really important that they know, that we are confident that they understand what we shared. We do need to review our next step, and then it's really important that we document in the file so that others know what we've talked about. A few extra tips, and we're getting close to the time of our discussion or large group discussion, but it's important, although many of our patients and families may want to know how long their loved one has to live or how long they have to live, it's important to avoid giving specific numbers. What we usually recommend is giving an estimate. So sometimes we say your loved one has hours to a number of days to live. Sometimes we say they have days to a number of weeks, or weeks to a small number of months. We wouldn't necessarily want to say we believe your loved one will die in 2 weeks, or we think that they might die in 2 days. That's very specific, and we can lose trust with our patients and families if we're possibly wrong. And then the other phrase that we've talked about before is that we want to avoid is there's nothing more we can do. It's very common for people to say that, even healthcare professionals to say that, but we want to begin to change that narrative or what we say to families. And instead we can say, although there's no cure for this illness, we will continue to support you and your child or you and your family and manage your pain and your symptoms. We know from all the training that we've had in this course so far that those are really critical and crucial to palliative care, managing pain and symptoms. And it is something we can say that we are planning to do, not that there's nothing that we can do. So just as we summarize and we think of some of our patients in these situations, it isn't easy. And I think we all of the faculty members that are with us or people that are providing palliative care in these settings, we all know that this is not an easy task. But we hope that as we get better at communicating, we can understand that this is really essential to palliative care. Using communication skills such as listening actively, using silence, as well as being empathetic is really important. And if you can start using the spikes model, the different steps that we talked about, it can be really helpful as you prepare to break bad news to your families and your patients. And just a final quote in terms of breaking bad news. If we do it badly, the patients and family members will never forgive us. If we do it well, they may never forget us. So that's your challenge for today. Thank you for listening to this, and we'll open it up for some questions. Thanks, everyone.
Thank you. Thank you so much, Erin, for the wonderful presentation. I'm sure we've learned a few tips on how we can communicate better. Is there anyone with a question? Feel free to type in the chat, or you can raise your hand so that we can have a few questions before we move to the case.
I think sometimes as we think about breaking bad news, we might actually re-traumatize ourselves, especially when you've been in situations where it hasn't gone very well. You had a plan, you felt like you were ready to share the information, and then all of a sudden your confidence was dropped. And you were faced maybe with a caregiver that seemed very upset, that felt like you weren't doing enough. I know right now I'm thinking from me personally of a case where we had to share very difficult news with a father of a 17-year-old that was dying. And it was very hard. We ended up over an hour and a half, and we were talking about the same thing over and over again. And these things are not easy. Yes, Leah, does this apply for pediatrics? It is very important that we break bad news, or we share prognoses with families, for sure. When we talk about the age that a child is able to fully understand a diagnosis, of course, you need to use your judgment there. I think we tend to, Dr. Nafula, usually begin with that question, what does the patient know? So if it's a teenager or someone that's 11 or 12, they may know that they're sick. Again, generally, you would probably, for children, tell the family first, the parents or whoever's the caregiver, and then not ignore the child, but engage with them and understand what they know. Their concept of death and dying and serious illness is obviously very different than an adult's concept of it. Dr. Nafula, do you have any other thoughts on sharing difficult news with children?
Yes, I think when communicating with children, it's important first to understand that we need to seek consent from their parents or legal guardians, because children cannot make decisions for themselves. And as Erin has mentioned, it's good to understand the level of understanding of the child, or at what developmental age they are at, because that's what determines how you communicate with children. For example, the ones who are less than 3 years, you might not be able to communicate anything with them. The ones who are maybe 5 to 7, you might want to use art or play therapy to engage with them. The teenagers, you might want to involve them also in the decision making, as much as they are still minors, but they have that sense of autonomy. But remember to always strongly involve the parents first and seek their consent before breaking bad news to a child.
Mm-hmm. Yeah, for sure. Any other questions?
Yeah, I'm seeing in the chat, everyone is saying thank you for the good presentation. breaking bad news is actually quite challenging for many healthcare workers. So
Yeah.
it's good to make sure that you have a good understanding about the illness or the issues around the patient, so that when they ask you questions, you're able to answer them. And we cannot overemphasize, but try and be as honest as you can. All right. Does anyone have any other question? I'm not seeing any question.
I think the other thing is that,
thank you.
Oh, yeah.
Thank you very much. I am Hassan. Bad news, you know, as you are here, you may see that nurses and auxiliary nurses that are not well trained, by the time the parents or the guardians ask the situation of the kid or the situation of the people, they may say that wrong things, because once the person trained and understand the important things of the dangerous things, that the bad news, maybe he may inform. He is not trained, he's not well trained, and he's not learned well. So he may say that the child has already died. So the problem is by the time before the training started, before the people or the auxiliary nurses or nurse are not trained, maybe they may inform a wrong information to the parents. As the most cases happen in the hospitals or the NCHs. Maybe currently in Paidebo, I stay in Paidebo. Maybe you may see that the people who are there, maybe they may not understand, or they have not passed the qualified schools in Somalia. Although you know that in Somalia last year that years we have in conflict in Somalia. There's a lot of challenges here around there. You may see that a guy went to the school, and he only go to up to class 5 or class 6, and by the time he completed or standard 8 somewhere there, that he don't have a good qualified teachers. So by the time he grown up, here they discuss about this tribal issue. So a mother or a father tells you that bring, I want to, you go to the hospital. He may say that I personally, I want my kid to get job, although he don't have the quality and capable that to do the work. So he go direct to the manager of the hospital. He say that I am that tribe, unless or otherwise, my kid to be taken to the hospital. So I will not be, I will not accept what you are doing here. So he may use forces. So then after,
I think it's a good point,
those,
Hassan. I'll just interrupt you. I think it's a good point. From what I can see, what you're sharing is that sometimes our colleagues are not, you know, they're not necessarily highly trained. So it is a risk that if someone has access to a chart, or they've heard that someone has been diagnosed with a severe illness, or maybe are end of life, that someone would preemptively, before a nice meeting could be set, someone who's not necessarily highly trained is sharing this information. I think what you need to do in your situation is you need to make sure that the team understands that the primary clinician, so whoever is the primary person taking care of the patient, is the person that's most responsible to share this difficult news. So for example, in Kenya, in Nairobi, you would have a primary consultant or a primary physician that's taking care and is taking care of full responsibility with the patient. In Baidoa, it might be a little bit different because you may not have access to specialists or clinicians, but whoever admitted the patient to the facility probably is the one that needs to take the responsibility of sharing difficult news. In your team, there might be mistrust of who is the one who ends up sharing the news. But I think ultimately is the person that's writing their orders, the person that's admitted. And then you probably need to work on teamwork. So you need to make sure that that primary person also empowers the nurses or the bedside aides or the auxiliary nurse, like you were saying, to make sure that they're not creating more anxiety for the patient, or not creating confusion, sharing more information about the illness, because they might not know how cancer progresses, or they're going back to more traditional ways of thinking about illnesses. Probably it's a combination of both. And I would suggest that you try and see, or even have a team meeting about this. How do we like deal with patients when they're diagnosed with a serious illness, or any illness? How do we share with patients when they have a diagnosis? You tell them that they have HIV. You say that they're TB positive. I think in many situations, we actually probably don't tell people why they're in the hospital. And this is something we need to work on.
All right. Thank you for the comments and the questions. We can keep typing any further questions we might have in the chat. We would like now to move to the case presentation, where we will still do more about communication. And our presenter is Annalice. Annalice is a nurse with vast experience working in the humanitarian setting. She's actually been working in Dadaab with ICRC for a very long time, and she's very passionate about palliative care, and she's done very many projects to improve the care of patients with life-threatening and life-limiting illnesses at Dadaab. And today she's going to lead us through the case presentation for Breaking Bad News. Welcome, Annalice.
Thank you, Dr. Nafula, and good afternoon to everybody.
Good afternoon. We can hear you well, yes.
Okay. The main concern of this for today's discussion is how to communicate with the patient and their family when they had had a recurrence of their condition that is very serious. I'm sorry, I'll not introduce myself again because Dr. Nafula has done it clearly. Thank you. Next slide, please. The case details of Breaking Bad News. This is a 65-year-old man who came to us 2 weeks ago with pain in his chest and belly. He has a history of right-sided lung cancer and had surgery 2 years ago. His wife, he was with his wife and his 2 children. He has 2 children also grown up who are staying next to the home. I mean, they are neighboring. And then on examination 2 weeks ago, he was found to have enlarged liver and suspected fluid in his right chest. And then scan was done and sample was removed from the chest, and fluid was tested and confirmed of extensive recurrence in his lung and liver. He was previously told by his surgeons who had done an operation to him that he was cured. Next, please. Next slide. So how will you tell him this news? Class will like to outline the steps how you think about before seeing him, how you will handle him. Then we have to review the way to discuss these results with him and his family. So we decided to take the spike mode, and we invited the patient over after receiving the results. Next, please. So I don't know if I will wish somebody to answer me this before I continue, please. I wish to see the answers of my listeners, what are the important consideration here? On the
Yeah,
chat,
people,
please.
if they want
Yeah.
to put in the chat, they can.
May I try?
Yes,
Yes.
please.
The first of all, the important things that you are considering to hear is, first of all, you just sit with the patient, you listen the place that he has pain, or he has the pain that he has, and you listen, and you take also discuss with him, and you counsel him before of all. You have to counsel him the sickness that he has, because some people, they think that they are not, they don't have counseling. Before you have to give the counsel the person, you have to tell him that this thing is sickness. By the time you take the drugs, the way the teacher, the doctor told you, the prescribe, and you have to counsel him that first, and you listen him the pain, and you counsel him information. Thank you. That's my trial.
Thank you. That is fair. And then on the chat, I can see somebody has said you set up a quiet place. That is correct. As we have been told by Erin, that we have to set up a place, a quiet place, and you have to be sure of whom to invite in the meeting. And then you have to have also the information ready before you call the team together with the patient and the relatives. Then perception, what words will you use? We have been told also to use words asking the patient and the relative to inform us on what really they know about the condition and what they expect to know about more. So that's what we did. We set up a place for the family. We asked them to come over after 2 weeks. The results were out, so they came. Next, please. So in setting up the place, we had to find a quiet place because our place in the ward, we don't have any private place. So we looked for a room next to the ward, and we had to sit there with the patients and the relatives. And the team was coming. So I passed the information that I hope we can discuss what you have learned. We had learned before when he came. We talked about his illness and the recurrence. That's how he accepted to be taken samples and the CT scan. And then we had to invite in the team. The counselor was invited, the psychologist, another nurse to support, and the patient and the relatives were there, and his wife and his 2 daughters came. And then we had to make sure that we had all the tests and the results and the papers ready. Next, please. Well, in the perception, we intended to know what the patient was understanding about their sickness. Already they had been told they are cured, and now they have come back with symptoms that were distressing, difficult in breathing. There was marked weight loss than before. There was a weakness of the body and the limbs. As we all know, that cancer can really bring you down and can cause all sorts of body weakness and symptoms. And then we also wanted to know how the relatives felt about the illness. And then we had the doctor to tell the condition about the medical officer was around, who had referred the patient for examination, and all that also had to do to reveal everything about them. On inviting the patient, what words will you use to invite this patient to speak about their condition and to make sure that they are accepted to come? Anyone please can speak. Referring to what we have been taught about by Erin, invitation. So when inviting the patient, we had to ask them, ask the patient how he felt about the condition and the previous procedures done to him and how he feels at this particular moment. And we gave them the free moment to speak and express themselves. And then what they wanted to know, we had to inform them of everything that we knew about cancer, the transmission, the symptoms, and the differential diagnosis. The doctor was able to explain to them how we were able to differentiate between the cancer of the lungs and other conditions which present with the same symptoms. Next, please. Yes, as you see, I just asked to know what was happening to the patient. And then I wanted also to tell them what is happening about the condition, the metastasis that have taken place, and that's why the patient was having the distension of the abdomen and the fluid in the lungs and the liver, cirrhosis, because when the cancer goes into the blood can cause a lot of infection to the other parts, like the bones, like the liver, and then you get the patient comes with jaundice, the patient comes with the enlargement of the body and all sorts. And then the knowledge, after the patient was comfortable enough to receive the information, they gave us the go ahead to give the information. I told them, I'm very sad to tell you, but I have bad news. The condition that the patient had was already deteriorating, and that's why he had, after the surgery, the cancer has progressed. This is why he was having more symptoms of breathing and feeling so unwell. Actually, the patient had already reduced in weight from 56, he was already weighing 40. So as you see the picture of the cancer stages, back, please. Yeah. Now, when your lungs are well, you breathe in properly. The air entry is okay. You don't have any pain in the chest. You don't have anything. You don't have cough. But when you are infected with the cancer, you'll have difficulty in breathing. You'll have cough. You'll have that breathlessness. You'll have even on sleeping. You may not sleep well. You feel tightness in the chest. And then when it spreads, now you will have completely even the headaches and whatnot, because there is no enough blood circulation going to the head and no oxygen at all reaching your brain. So you'll have a lot of headaches, you'll have weakness of the muscles and even the nervous system. Next, please. So we went on to give the patient more information as much as the patient and the relatives could contend, that your lungs are having to work hard, and since the cancer is growing, you are not able to feel as well as you have been feeling. Exactly, that is what happens when the cancer has already spread, and the fluids that is building up in your lungs will most likely
I don't see the slide. Is it my problem or with everybody?
We can see the slide.
I think it's there.
Check your screen.
Sorry. I will also share the slides after. Sorry about that.
Can I go on?
Yeah, I think so. Yeah.
Yes, please.
Okay. In being honest, we had just to inform the patient that the fluid that was building up in the lungs will most likely to come back again, because if this condition has already spread, okay, there is no much that can be done, because the surgery was done successfully, and then unfortunately could have been a spillover, or it was already there but was not diagnosed in the other organs, but it has come. Now there is nothing more that can be done on the medical ground, but still there is something that palliative care together with the other teams can do. Next, please. Anybody who can answer for me this? How do you acknowledge this emotional empathy? Okay, in feeling what the patient could have felt, actually this is a very complex case. It is recurring. The patient had already received that bad news before they started the extensive treatment or the intervention, going to surgery, going through all those, and now again, it has come back again. This patient was really feeling devastated, and now he really needed something that will calm him down. The family was already being drained. They have been drained to pay for the surgeries and everything. And now the patient again is back in the worse state than he was before. So we needed to calm him down, the family, and the counseling session had to be put frequently, because the patient actually accepted to be admitted in the ward. And then now we had to do it almost frequently to make sure that they are at least in a stable condition, both the patient and the parent, to accept any eventuality that will come. As they said, the will of God may be done. They accepted. That was one good thing. And then the family needed really support, both psychologically, emotionally. All this the patient was able to get, but before continuing to giving more information, the patient had to be given time, at least to just accept what we had told him. We needed time for that, as it was too much for them. And also ourselves, when you are giving bad news, you cannot talk without also reflecting on yourself. Well, how do you feel about the situation of this patient, and how will they feel? How do they feel, and what wish do they have different to their situation? Then we have to use the nurse and then respond to the emotion, understand what they are feeling. We have to acknowledge everything that they are doing. We have to respect their opinions. And then we have to tell them about how they are feeling also. We need to them to understand how they are feeling and how we are feeling about the condition. Next. We could not leave the patient to go empty without letting them ask questions. So we have to ask them if they have any question. The family, the parents, the daughters asking if there is anything we can do. If there is anything the doctor can do, will the patient go back for the next, another operation? Will the patient be well? How long will the patient take in the hospital? Will he be able to walk? Because at one point he was not able to walk because of the weakness of the lower limbs. And then also the tapping was going on. At times he could not go for toilet by himself. He needed support. They were worried how long it would take for them doing that and for the patient in that state. So we managed to inform them that it may take long. Either the patient may recover or the patient may not recover. Or he may recover but not fully. Then we had also to document what we had discussed. The nutritionist had to document and share about his nutrition because of the liver and now the ascites. We needed some direction on nutrition. So the nutritionist had to share about the feeding of the patient and what best to feed on regarding the locally available foods that they can afford, either from the hospital or from home. And then the patient's file has to be kept confidentially, not to be accessed by other people apart from those who are authorized to. And then those who will come later, they will know what we have discussed. So everything has to be documented because there are shifts in the hospital. Then making recommendation for the next step, we had to inform the patient that based on your medical condition and what you have shared with us about what is important for you and your family, we recommend that we make a plan for how we can help you to feel comfortable at the hospital and at your home. But because the patient, they are after counseling for long, they accepted to remain for some times in the hospital as some of the conditions are being relieved. So we had to wait until they are due time for going home, and then we discuss more again. But for currently, we had to discuss what was there at the point, how the patient will be taken care of, relieving symptoms, and how the family was going to be taken care of. Next, please. As I had said earlier, this is what happened exactly. The patient family, they said, we know God is a God of miracle and he's likely to do some miracle. We couldn't have refused the statement. We accept, we are the patient, we agree with them, But again, we also worry that the condition is not comfortable for healing, but we just try to make the patient comfortable by relieving the symptoms. When time comes, they have to accept, because that is also another miracle. When God brings is a miracle, when God takes is a miracle. So we have to console them that way. Next. Our family strength was that they had strong belief that they love their loved ones will be helped, and they have trusted that with our support they will get any assistance they may require. So ours was just to treat the symptoms as they come, the fluid in the stomach, we drain, and that is all. After the patient and the family were made aware about the prognosis, that they have difficulty, they had difficulty in accepting that there's no more treatment available to cure their loved ones. But after multiple counseling sessions occurred with the healthcare team, the patient and the family were in acceptance for repeated counseling session and requested to stay at the hospital until he was more stable, and then planned to take him home. So 2 weeks ago, the patient is still in the hospital. So any question?
Anyone with a question to Annalice? I've seen there are some questions in the chat, but if there is any specific question you would like us to address before we take the 2 questions in the chat. So someone has asked the situation where relatives, a patient comes with a poor prognosis and relatives tell you not to disclose their diagnosis or bad news to them because it will make the condition of the patient deteriorate. Now, there's a concept called conspiracy of silence, which is actually unethical. When healthcare practitioners collude with family members to hide information from patients. If you read the Patient's Right Charter, patients have a right to information about their diagnosis, their prognosis and treatment options, and the patient has a right to decide what type of treatment they should get. So it is their right to get information. So usually how we handle that situation is to try and understand why the relatives feel the patient should not be told that news. And most of the time you'll find that it's the relative who is having a hard time coping with the information more than even the patient. So you need to support them to cope with that bad news first before we can be able to disclose to the patient. But it is important to realize that treating a patient without disclosing their diagnosis is medical malpractice. It is unethical. So the patient needs autonomy. They need to understand what they're being treated for, and they need to be enabled to participate in decision making. Now, sometimes the patient is already sick and their situation is deteriorating. So it is not the bad news that is making the patient to get sicker. It is just that the patient was already sick and their prognosis was already bad. So they are bound to get worse, not because of the bad news, but because of the underlying diagnosis. We'll answer one more question before we wind up, that how possible is it to break bad news to healthcare providers who have terminal illness, who already understand their prognosis? Healthcare providers are sometimes the best patients because they already understand, but because of having knowledge about an illness, they also tend to have a lot of anxiety and a lot of depression because of the understanding what kind of diagnosis you have or what your prognosis is. So the best approach for discussing with healthcare providers is probably just to ask them what they want to talk about, or how open-ended questions. How does your illness make you feel? What are your current worries? Because they already understand the science of their disease. And some of them might not be open to talk about it. They might not want to talk about it because they already understand their prognosis, and they may tell you they do not want to talk about it. So you build onto subjects that they are willing to talk about. And some of them will talk about it. And most of the time it's about their anxiety and their worries, and generally just the psychological issues that come around with illness. Because if you're sick, for example, you've been diagnosed with terminal cancer and you're a doctor, you're a nurse, you're a social worker, you deal with these patients all the time. So you really do understand what is happening with your body. Sometimes they just need someone to talk to. So we do not focus much on discussing about the illness or prognosis, but rather what they want to talk about. Now, there's the attendance sheet. We've shared the link on the chat. Please click on it and sign the list as we wind up. Erin, do you have any further comments before we wind up?
No, we're just getting close to the end of the course. There's only 11 weeks in this course. So I think we have only 3 more classes. So we're going to take a break over the Easter holiday. And I know a lot of our participants are also celebrating Ramadan right now. But just if you wanted to write in your schedule or your calendar, we will have a class next week, April the 4th. And then we're going to take a break on the 11th. And then we'll have the 18th and 25th. So I think because of Eid, the end of Ramadan is around the 21st, 22nd, we should be okay. But if you have any issues and you're on leave or something like that, just email me. This course is fairly flexible. But yes, next week, the focus for next week is, sorry, give me 1 minute. Next week, we are going to be focusing on spirituality for palliative care patients, as well as grief and loss for patients and families. So as we think about grief and loss, we sometimes do need to counsel patients before they die, as they experience different losses. Maybe they've not been able to work, or they have different types of losses as they progress with their illness. So, yeah, so that's the topic for next week. Hopefully you'll be here same time. And if you had any issues connecting, you can always listen to the recording. But thank you, everyone. Thanks so much, Annalice. Thanks, Dr. Esther. The time will still be the same in April, yeah. So same time as today.
Thank you. Thank you, everyone, for attending.